these are like really challenging conditions because they are imposing a more refractory stage of a status epilepticus which have failed the initial medications. And the challenge that impose is that these stages of a status epilepticus require high dose of anesthetics that can be associated with long-term ICU complications, more time in the mechanical ventilations, and also complications with the hospital. New data has shown that the use of anesthetics has not been associated with mortality, which I think is something really good for us to know, because there's some fear into starting these medications and giving an adequate dose of this medication for the management of status epilepticus. The underlying etiology of the disease is the one that's going to lead the mortality. Challenges that we have in terms of evidence is that we don't know which of the anesthetics is the best to initiate for the management of super-refractory status epilepticus or refractory status epilepticus, and we need more data to collect in order to see which one is the best agent to start immediately upon being in these stages. In general, for status epilepticus, we have really good data that benzodiazepines really work. However, the majority of the patients tend to be underdosed for benzodiazepines. One of the biggest trials that was recently published in 2019, the ESSE trial, in post-hoc analysis showed that 70% of these patients were underdosed with benzodiazepine. So I just encourage all my colleagues to please give an adequate dose of benzodiazepine medications early on, because that's going to prevent the progression of the disease, and it's not been really associated with increased number of intubations. Other thing that is challenging in the early stages of status epilepticus is that once they have failed benzodiazepine, we have 3 well-studied drugs, Levetiracetam, Valproic acid, and Fosphenytoin, and all of those are 50% efficacious. So we need any other other drugs or any other interventions in these early on stages to stop the progression of the disease. Now, there is studies going on that it can be used in patients that have failed these 2 medications. One of these drugs is attacking the GABAA receptors that are outside the synaptic cleft. And I'm hoping to see the results for this study because it is very promising in the management of our patients, so to prevent the use of anesthetics and intubations, as well because it's preventing the progression of the disease. There's limited data for neurostimulation techniques, and those have been used most in the late stages of status epilepticus. One of the new interventions that I am passionate about and I'm looking into is into the replacement of pyridoxine, which is vitamin B6. Vitamin B6 is a vitamin that once it gets phosphorylated in your body, it transforms to an agent called PLP that is a critical cofactor for the development or the production of GABA neurotransmitters. And my team showed 2 years ago that about 80% of our patients that have established status epilepticus have deficiency of vitamin B6. So there's an association between deficiency of vitamin B6, and this is after correcting for other critical illness scores, and also when we compare to other groups, patients that were also admitted to the ICU, patients that were admitted to the hospital, and outpatients. So there's some promising data into possible replacements of B6. It's something that I'm very passionate about. But in terms of neurostimulations, we have very limited data into how it's working in the later stages to really extrapolate their efficacy for earlier stages. So I think we're early on in that term of management.